The San Antonio Breast Cancer meeting has just finished, and with me is Professor Matteo Lambertini from Italy, from, in fact, the University of Genoa, San Martino Hospital in Italy. Matteo, you've been talking about a very important issue because we all know that BRCA1 and 2 carriers face a risk of breast cancer, but what about the ones who've already had breast cancer? What do you do with them? You've got some surgical options and you've been investigating these with a massive study. Give me the background to this. Why did you want to study this issue?
Yeah, indeed, we know that risk-reducing surgeries, so risk-reducing mastectomy and risk-reducing salpingo-oophorectomy, are recommended in BRCA carriers. However, most of the evidence behind the role of this surgical procedure exists for BRCA healthy carriers, with a bit more limited data for those patients that have already been diagnosed with breast cancer. And in this specific setting, so patients that already develop a breast cancer and are also BRCA carriers, we should keep in mind in the counseling that there are additional challenges. One of them is to consider the risk of recurrence versus the risk of developing a second primary malignancy. Second, the lack of clear evidence, particularly for risk-reducing mastectomy, on the benefit in terms of survival advantage. And finally, for young women, particularly which is the target population of our study, all the reproductive consideration behind the use of risk-reducing surgeries.
Let's get this quite clear. In the case of the carriers who've not yet had cancer, there are clear benefits, and they're different between salpingo-oophorectomy and bilateral mastectomy, aren't they?
Exactly. Bilateral salpingo-oophorectomy has a clear survival advantage. This has been demonstrated by many studies. However, for risk-reducing mastectomy, the beneficial effect in terms of reducing mortality is controversial. All the studies have shown that undergoing risk-reducing mastectomy significantly decreased the risk of developing a second primary breast cancer, as expected, but the benefit in terms of survival advantage is controversial. And it's even more controversial in those patients that have already been diagnosed with breast cancer.
But you're dealing with patients who've actually had a diagnosis of breast cancer. Tell me about this patient cohort. Who were they, and why did you do this particular investigation?
Yeah, our study focused on a special patient population that are those women with a BRCA pathogen or below. So it's a special population because it's young women with breast cancer at a young age plus BRCA carriers. And this is a large international network that we have named as BRCA-BCY collaboration. This network started almost 10 years ago to try to answer the question on the safety of pregnancy after breast cancer in this special patient population. These data were reported in JCO in 2020 and then in JAMA at the beginning of 2024. But then within this large network, we collected a lot of other important information that we are currently using to analyze other potential unmet needs that our young BRCA carriers with breast cancer may have. And one of them is indeed the value of risk-reducing surgery in this special clinical context. And I really want to emphasize once again that this is a special clinical context because it's young women with breast cancer at a young age plus BRCA carriers. And we managed to include 5,290 patients within this large international network.
Right, so could you tell me what you did then in this very large study?
Yeah, in this specific analysis, we looked into the effect, or to be more precise, the association between the risk-reducing surgeries and survival outcomes. So, in other words, we have looked into the potential beneficial effect in survival of undergoing risk-reducing mastectomy and or risk-reducing salpingo-oophorectomy. And the main results from these studies that both surgical procedures, so risk-reducing mastectomy as well as risk-reducing salpingo-oophorectomy, are both associated with a significant improvement in overall survival, disease-free survival, and breast cancer-free interval.
How big an improvement was that in overall survival?
Yeah, the improvement was very important. For risk-reducing mastectomy, the adjusted hazard ratio was 0.65, so meaning a 35% reduced risk of dying for those patients that underwent risk-reducing mastectomy. And for risk-reducing salpingo-oophorectomy was 0.58, so more than 42% reduced risk of dying. And a similar advantage was observed for both surgical procedures for disease-free survival as well as for breast cancer-free interval, so a major survival improvement.
So how would you, if you go on to apply this, how would you apply it the decision making between salpingo ovarectomy and bilateral mastectomy.
Yeah, I think that for risk-reduced salpingo ovarectomy, this data will further reinforce the current recommendation by guidelines that this is a surgical procedure that should be recommended to all BRCA carriers between the age of 35 to 40 years if BRCA1 mutated, or 40 to 45 if BRCA2 mutated. So I think this data will further reinforce the importance of this recommendation. To me, the most important news is probably the risk-reducing mastectomy result, because this survival and a huge survival advantage that we have shown was controversial in prior studies, and to me this data should be applied in this special context. So for those women with a prior diagnosis of breast cancer at a young age, then the role of risk-reducing mastectomy is very important, and it's probably the counsel should be a bit more aggressive than what we do with healthy BRCA carriers or BRCA carriers diagnosed with breast cancer at an older age. So this is a special population, patients that have already developed a breast cancer at a very young age and are also BRCA mutated. In this case, I think the counsel should be a bit more aggressive in this regard.
And we must say this is a huge study, so you're really certain of your findings here, aren't you?
Yeah, of course, it's a retrospective study, so there are potential biases with this sort of studies, and also the type of analysis is quite complex with different potential biases, but we have tried to counteract as much as we could. We built a very strong statistical team behind this analysis. We performed different models, different sensitivity analysis to try to balance as much as we could for potential biases. And all the results were very consistent with all the different models. So despite it's still a retrospective study, we do believe into these results.
Now, there are toxicities, of course, because women do have changes because of these procedures. How do you rate the importance of those, and how do you discuss the psychology of this with your patients?
Yeah, this is of course very, very important to be done. All these women should be counseled, should receive psychological support and counseling before undergoing any risk-reducing surgery. Probably the most important one is the risk-reducing salpingo ovarectomy, that has also important implication in terms of reproductive implications. And so fertility counseling, this is key and highly relevant to be conducted before doing any type of this surgical procedure. Should be very clear, and all the fertility procedures should be recommended and offered to patients before undergoing this procedure. But the same will apply also for risk-reducing mastectomy. I think it's very, very important to discuss the potential side effects, the potential also surgical complication, of course, but I think we should be also very clear on the survival advantage that such a strategy can have in this special clinical context.
From your experience so far, how have your patients been reacting if you recommend these procedures to them? Do you recommend them already?
Yeah, we do recommend for the risk-reducing salpingo ovarectomy. I think it's very clear since many years the age at the time this procedure is recommended, and patients are very much aware on the importance of this surgical strategy, despite all the side effects of early menopause and the fertility concern. But there are ways to counteract these side effects using non-hormonal strategies that may help in improving the side effects of early menopause. In terms of risk-reducing mastectomy, again, this is a special population, so these are women that have already developed a breast cancer at a young age. So also in their mind, the possibility to remove both breasts normally is, they are probably the one proposing to us to undergo a bilateral procedure, even before sometimes we propose to them. It's important that we don't overstate or overcure our patients. So outside the BRCA field or other special clinical situation, there is no need, no indication for bilateral mastectomy. But in these special cases, breast cancer at a very young age plus BRCA pathogenic or likely pathogenic variants, in this case, indeed, a bilateral surgical procedure should be considered probably the preferred option.
In your practice, your own practice, what's the uptake of these procedures? Is it very high?
I would say that it's very high. It's probably changed over the past few years. In the study, around 40% of the patients underwent this procedure. Overall, in the overall cohort, around 55% of the patient. But then if you look at the time of diagnosis, so like close to the age of breast cancer diagnosis, it's around 40% of the patient that still decided to undergo conservative surgery, even knowing to have a likely pathogenic variant in the BRCA genes. I think that this percentage is gonna become smaller in the future, so probably more patients are gonna choose for a bilateral intervention or at least unilateral mastectomy at the time of diagnosis if knowing to be BRCA carrier. And one of the reasons I'm saying that is that we are now testing more women, so more patients know to have a BRCA pathogenic or likely pathogenic variants at diagnosis. And then for those that don't, and these are young women again, we normally do a sort of called urgent BRCA testing, meaning that we have the results in few days, a couple of weeks, and so these results may be used by the patient and the healthcare professional to make a counseling on the also on the potential surgical choices for the breast surgery as well.
What about the clinical implications? How do you counsel your colleagues around the world to handle this situation from now?
From now, I will reinforce the recommendation of guidelines for risk-reducing salpingo-oophorectomy, so to strongly advise all BRCA carriers between the age of 35 to 40 years, if BRCA1 carriers, 40 to 45, if BRCA2 carriers, to undergo the gynecological risk-reducing surgery. For the mastectomy, as I've mentioned, I will be more pushy in terms of recommended, I will say strongly recommending to undergo risk-reducing mastectomy to all young BRCA carriers with prior diagnosis of breast cancer at a young age. I don't want to overuse these results, so as we stated in the conclusion of our presentation, we don't want to use this data for counseling all BRCA carriers or BRCA carriers with breast cancer diagnosed at the age of 50 or 60 years. This is a special population, so this data should be applied to young BRCA carriers with breast cancer below or up to the age of 40 years.
Okay, so could you give me a quick summary of the headline finding and what this means very simply to doctors around the world?
In our San Antonio Breast Cancer Symposium 2024 presentation, we presented the results of the BRCA-BCY collaboration, which is a large international network including more than 5,000 young BRCA carriers with a prior diagnosis of breast cancer. In this specific analysis, we looked into the association between risk-reducing mastectomy and or risk-reducing salpingo-oophorectomy and survival outcomes, and we've seen that these surgical procedures significantly improve the survival outcomes of our young patient with breast cancer and carrying germline pathogenic or likely pathogenic variants in the BRCA genes. So I do believe that these results should be used in the counseling of this special patient population on risk-reducing surgeries.
Matteo Lambertini, thank you very much. You've joined me from Genoa, just in the wake of the wonderful San Antonio Breast Cancer meeting, the 2024 meeting. I'm Peter Goodwin for the Audio Journal of Oncology.